Hi everyone, my name is Melissa Robertson and I am going to be discussing Chapter 33, Cerebrovascular Disorders. So we're going to start off by looking at the central nervous system and the peripheral nervous system. So your central nervous system, or your CNS, that's the brain and the spinal cord, and you can see in this picture how it's kind of sectioned off. So you see the brain and the spinal cord at the top. That is your CNS, and then your peripheral nervous system, or your PNS, that is your cranial nerves and your spinal nerves. Now you also have some sensory and motor sections around the midline of the brain, and that is where these motor neurons actually go down the spinal cord, and then the sensory neurons go up from the spinal cord. So you see these kind of intertwined and working together, but just be able to differentiate the two. The central nervous system is your brain and spinal cord, and then your peripheral nervous system consists of your cranial nerves and those spinal nerves. Okay, so the central nervous system, we said, is the brain and the spinal cord, right? So we're going to talk a little bit about how this is broken up. So the brain actually has different regions. We're going to start with the cerebrum. This is most of the brain tissue. So it has a right and a left hemisphere. Now, keep in mind, whenever one side is damaged, you're going to see the action on the opposite side of the body. So if there is damage to the right hemisphere, you're going to see that displayed on your patient in the left side of their body. And we'll talk about that a little bit more whenever we're talking about stroke. But just know cerebrum has a right and left hemisphere, and each of those hemispheres has the frontal lobe, your parietal lobe, your temporal lobe, and your occipital lobe. Now, I have on here a picture of each of these you can look at. You also have a box in your text, box 33-1, that you can reference back for this, but I just want to talk about each of these just a little bit. Each lobe. So the frontal lobe is responsible for memory, for voluntary movements, for emotions, for judgment, decision making, for reasoning and aggression. Your parietal lobe is responsible for receiving and interpreting sensations, and then also proprioception, which is the awareness of your body and body parts in relation to each other. And then the temporal lobe is responsible for hearing, smelling, learning, memory, emotions, and visual recognition, and the occipital lobe analyzing and interpreting information. So keep in mind, if any of these areas are affected, those things are what's going to be affected, right? So if the parietal lobe is affected, then you're probably going to see some changes in their speech, right? So just keep that in mind, especially when we're talking about stroke, because you are definitely going to see that come into play. So moving on, we also have the brain stem, because we're talking about the parts of the brain here. We're going to talk about the brain stem on the next slide. And then we have the cerebellum. So cerebellum is responsible for coordinated movements, for posture, for equilibrium. And in this case, if this area gets damaged, it will affect the same side of the body. So here, this is kind of where your motor skills are stored. So if you learn something that's a motor skill, so let's say like throwing a basketball through the hoop, then it's stored here so you don't have to constantly relearn that particular skill. So I want to draw your attention to these two areas of the brain. There's Broca's area and Wernicke's area. So Broca's area, as you can see here, is responsible for the ability to speak. Wernicke's area is responsible for the ability to comprehend. So what happens if these areas are affected by some kind of brain injury or a stroke? So you can see expressive aphasia and dysfunction here. So expressive aphasia is with Broca's area. That is where they can't actually put the words together, but they can understand what you're saying. And then if Wernicke's area is affected, the patient will have receptive aphasia. So that's where they can speak, even if the words seem like they don't make a lot of sense. They can speak, but they can't understand what you're saying. So they can't comprehend, they can't process it. So we are still in the central nervous system. We are going to talk about the brainstem. The brainstem consists of the midbrain, the pons, and the medulla. So the brainstem allows nerve fibers from the spinal cord to connect to the cerebrum. Damage here can affect the cranial nerve function, which we're going to talk about those 12 cranial nerves in a couple of slides from here. The important thing to know here, so brainstem is super important. The major player here is your medulla. This is your vital signs center, so that controls cardiac and respiratory function. This is super, super important, right? Because any damage there would be reflected in your patient as cardiac and respiratory dysfunction, right? Their vital signs would be impaired or knocked out completely. So this area definitely is one that can be dangerous if it's impacted. So how is the brain supplied with blood? Most of that oxygen and blood supply comes from the vertebral and carotid arteries in the neck. That vertebral artery will branch off to the subclavian to supply the posterior brain. And then also there's a middle cerebral artery that supplies most of that brain tissue. So most strokes involve something in that particular area, in that middle cerebral artery. So now we're moving into the peripheral nervous system, or the PNS. So we're going to talk about those cranial nerves. I know I mentioned them a couple slides back, but we are going to talk about these 12 pairs of cranial nerves. So they can have a motor function or a sensory function or even both. So these cranial nerves do sense changes in the brain itself. They start at the brain and then they go to the head, to the face, to the neck, and to the shoulders. So you'll see with like a stroke or a brain injury that these cranial nerves will not function correctly. So again, because of that damage, it will cause a dysfunction in how these cranial nerves operate. So we're going to talk about each of these cranial nerves. There's different little mnemonics that you can look up, that you can remember. So these cranial nerves, in this particular picture, it is broken down to where they are coming from the brain, but also if they have a sensory function, a motor function, or both. So for the olfactory, so cranial nerve number 1 is olfactory. That is a sensory neuron, and its basic function is smell, just right from the term, from olfactory. Now the cranial nerve number 2 is your optic nerve, and that one is sensory, and of course it is in charge of vision. Cranial nerve number 3 is oculomotor, so it says it right there, right? Motor in the word. That is for eye movements and pupillary responses. And cranial nerve number 4 is trochlear. That is a motor function, motor neuron. It also focuses on those extraocular eye movements. Cranial nerve number 5 is trigeminal. So that one is both motor and sensory. So it will detect facial sensations and then the muscles involved with chewing. Cranial nerve number 6 is abducens. That is a motor neuron function, and that one is involved in extraocular movements as well. Cranial nerve number 7 is facial, and that is mixed motor and sensory, and that one is in charge of facial expressions and then taste over some of your tongue. Cranial nerve number 8 is auditory or vestibulocochlear. You can use either one. It is a sensor. It is involved with sensory function, and it is involved with hearing and equilibrium. Which auditory or vestibulocochlear kind of tells you what it does. Cranial nerve number 9 is glossopharyngeal. This one is mixed. It is motor and sensory functions. So for this one, you're going to see it's going to have to do with swallowing and then taste over a portion of the tongue and salivation. So how does that saliva come into the patient's mouth? And then number 10 is vagus. That is motor and sensory as well. This has to do with their gag reflex. So if a patient's vagus nerve is affected, that gag reflex will be affected. Cranial nerve number 11 is accessory. This is a motor function, and this one, it has to do with them being able to turn their head side to side and then shrugging their shoulders. Cranial nerve number 12 is hypoglossal. So just that word glossal, that's like tongue, right? And this has to do with tongue movement. So again, you know, it is motor with that movement function. Okay, so we are going to talk about stroke for a little bit. Stroke is the 5th leading cause of death in the United States and the leading cause of disability. So just because the stroke does not cause death in a patient does not mean that there's absolutely no complications whatsoever. So there's 2 different kinds of stroke. There is ischemic stroke and hemorrhagic stroke. So ischemic is where there is ischemia of the brain tissue. Hemorrhagic is whenever there is a hemorrhage in those blood vessels within the brain itself. So stroke itself is a specific type of brain injury that is caused by hemorrhage or ischemia, like we just said. There is a disruption in that blood flow in the brain, and that causes a permanent neurological deficit. So once these complications are there, they are not going to be reversed. It is permanent. So first we're going to talk about an ischemic stroke. So remember, an ischemic stroke is where there is ischemia in the brain tissue. So there's something that is obstructing blood flow to a part of the brain. Something is obstructed and there's not enough oxygen, there's not enough blood flow that is getting to the brain itself. So remember, ischemia leads to cerebral infarction. And what does that mean? That means that that is death of the cells in the brain. So that's an important term to know. So what causes an ischemic stroke? There's 3 main causes. One is arteriosclerosis of that cerebral artery. So arteriosclerosis, remember there's plaque and stuff building up. So there is a piece of plaque that can break off and form an emboli. That emboli can occlude that cerebrovascular vessel, and that will decrease or obstruct that cerebral blood flow. There's also atrial fibrillation that causes an emboli, and then there's also carotid stenosis, which we're going to talk about both of those on the next couple of slides. So with atrial fibrillation, that left atrium is kind of quivering and it's not really pumping the blood out like it should be. So that quivering is going to lead to stasis of the blood, which means it's just sitting there. So whenever blood is just sitting there, what does it do? It sticks together, right? It forms a clot. So once you have that clot can travel to the carotid artery, and at that point, it would cause an obstruction in that cerebral blood flow, which would cause that ischemic stroke. So remember, these symptoms progress over time, usually over a few hours. It could be a few days, just depending on what the patient is experiencing. But once that cerebral blood flow is occluded, the patient will start seeing some symptoms. And we're going to talk about the symptoms in the next few slides. So carotid stenosis, when we were talking about the blood flow in the brain, we talked about the carotid arteries, right? That's really important when it comes to blood flow to the brain. So if there is stenosis of the carotid arteries, then you're going to see that obstruction. So this is where there is some arteriosclerosis of that artery, of the carotid artery. So that artery is really narrow from that plaque buildup. So there's a thrombus that travels to that cerebral artery, and it's going to occlude the blood flow. And then that, of course, is going to lead to ischemia. So transient ischemic attack. This is also called a brain attack or a mini stroke or a TIA. So we'll refer to it here as a TIA. This is similar to a stroke where they will have symptoms of confusion. They might be a little combative. They may not know what's going on. They may have some weakness, but it's not a stroke. So these symptoms will resolve. This is a medical emergency. These symptoms will go away within about 24 hours. Without intervention, without treatment, about 50% of these TIAs will the patient will end up having a stroke within about a year. So what is happening here? So for this one is where there's some kind of occlusion in the brain, in the arteries, in the circulation, and the tissue is not getting oxygen. So they will have those signs and symptoms that look similar to a stroke. that occlusion will be dissolved on its own. The body does its own thing. It will dissolve that emboli, whatever it is, it will dissolve that occlusion, and those deficits will go away within about 24 hours. Now, this is an emergency, as I said earlier, so they do need to go to the emergency room so that they can intervene and see what's going on. Maybe look at those carotid arteries, see if there's any blockage there so they can go ahead and treat that appropriately. So again, these symptoms will resolve on their own within about 24 hours. These are temporary symptoms. They can last for a few minutes or they can last for hours, but they will resolve on their own. So moving into a hemorrhagic stroke, this is where a cerebral artery actually ruptures. So there's no blood that's getting to that brain tissue. So with that blood that's leaking into the area, there's going to be a lot of pressure. So this type of stroke causes more damage. There's a lot more pressure because of that bleeding. So something to keep in mind here is Cushing's triad. This is where there is irregular respirations, decreased heart rate or bradycardia, and increased blood pressure or hypertension. So remember we talked about the medulla a few slides back, and that is like the vital signs center in the brain. It's because there's compression on that area, and that's what's causing these symptoms in Cushing's triad. This is not good. This is not a good sign at all, because remember that is like your center for your vital signs for those things that you need to survive, like heart rate, blood pressure, respirations. So if there is pressure on that medulla from all this bleeding, that is not a good thing for your patient. The first 24 hours after the stroke are critical for this patient. So whenever they're in the hospital, those first 24 hours, time is super important, because the longer these symptoms go on, or the longer there's less interventions happening, the more the brain tissue is being affected, and that's irreversible damage. So when we're talking about stroke, what are some things that put people at risk for having a stroke? The main ones are high blood pressure and atrial fibrillation. So they need to get that high blood pressure under control. If they can manage it so that it's not out of range all the time, then that will decrease their risk for a stroke. But if it is unmanaged high blood pressure, maybe they don't take their medications like they should, that is putting them at a higher risk for stroke. As well as atrial fibrillation. Some people just think they can live like that, so they don't take medications. But remember, whenever that happens, that blood just pools and forms a clot and can cause an ischemic stroke. So some other things that can put them at risk is their diet. If they have a diet that's really high in salt, high in fat, high in calories, that can definitely put them at risk, because remember, that affects their arteries, right? And so arteriosclerosis is a big risk factor for having a stroke. It's a precursor for a stroke. If their arteries are in bad shape, then that is definitely going to put them at a higher risk. If they use alcohol or smoke tobacco, that will put them at a higher risk. Diabetes, especially if it's uncontrolled, if it's not managed well, diabetes will put them at a higher risk as well. So remember, because diabetes will affect the arteries also, and that is what will put them at a higher risk here. That long-term high sugar is going to impact their arteries. Being obese is going to put them at a higher risk, which also has to do a lot with their diet. And then another thing is if they've had a previous stroke, or remember a TIA. If they had that and they didn't seek help, or if they didn't do the treatments that were recommended, like maybe managing their blood pressure, then they are definitely going to be at a higher risk of having a stroke. So we're going to look at the signs and symptoms of a stroke. So what would you see in a patient that was presenting with a stroke? So whether it is ischemic or hemorrhagic, both of those strokes will cause damage to the brain. So regardless of what kind it is, you are going to see damage done to the brain, and that's what's causing the symptoms. So keep in mind, strokes affect both sides of the brain, right or left. So we have our two hemispheres, and either one can be affected. Depending on which one that's affected, so for example, if it's the right side of the brain where there is the ischemia, right, or the stroke that's happening on that side of the brain, you're going to see the symptoms present on the opposite side of the body. So in this case, if it's the right side of the brain that is having the stroke, the left side of the body body is where you're going to see the symptoms presented, and vice versa. If the stroke is happening in the left hemisphere, you're going to see it reflected on the right side of the patient's body. So you will see different things affected here, so like their muscle weakness or their strength. That's where you're going to see hemiplegia or hemiparesis. This is where they actually have paralysis or weakness to one side of the body. You're going to see sensory loss and motor loss. So remember, we talked about those cranial nerves, and we talked about if they had sensory or motor function, either one. So that's where you're going to see some of these symptoms start coming out. If they have sensory loss, they'll complain of numbness, tingling, or no sensation to one side of the body. Again, if it was a left-sided stroke, a left-sided hemisphere in the brain, you're going to see the right side of the body affected. For motor loss, you're going to see them have difficulty with coordination, with balance. You might see this displayed in how they walk or their posture, how they're able to stand up, if they're able to at all. You're going to see some cognitive difficulty as well. So language, are they able to put words together? Are they able to speak at all? What is their perception like, or their attention? And then you may see some vision changes. Initially, when the patient first presents with symptoms, typically they will complain of some numbness or weakness on one side of the face or in their limbs on one side of the body. That's kind of what alerts you that this could be a stroke, because one side is affected. They may have some confusion or understanding what's going on. They may have trouble speaking. They might have some vision changes. They might have blurry vision or not be able to see at all. They may have some trouble walking or have some issues with balancing themselves. And then they may have a headache, especially with a hemorrhagic stroke. That's one of the main symptoms, is a severe headache. So let's take everything that we have discussed and put it together on a real person. Mr. Fields was found in his home by his daughter, unable to speak properly and exhibiting weakness on the right side of his body. He has difficulty lifting his right arm and slurred speech. His daughter called emergency services. When the paramedics arrived, they noted he had an irregular heartbeat and was slightly confused but could understand commands. He has a history of smoking. He quit 5 years ago, hypertension, and type 2 diabetes. So let's look at this and think about each of the following questions. Now pull back what you learned in this lecture and try to answer these questions. So what is the significance of Mr. Fields' risk factors? So he has hypertension, type 2 diabetes, and a history of smoking. So we know that there are certain life choices that can increase the risk for having a stroke, and one of those is certainly smoking, right? We don't have an age for Mr. Fields, but we just know he quit 5 years ago, so he has a history of being a smoker. On top of that, hypertension. Remember, that's one of our top risk factors, is hypertension, and as well as diabetes. So he definitely has some risk factors, multiple risk factors, that put him at a higher risk for stroke. What are the key signs and symptoms of a stroke that you would look for in a patient like Mr. Fields? So Mr. Fields was unable to speak, and he had weakness on one side of his body. He couldn't lift his right arm, and his speech was slurred. So those are definitely symptoms. Those are some of the main symptoms that we would want to look for in a patient that could be having a stroke. Describe the difference between an ischemic and a hemorrhagic stroke. So think back to what we discussed. Ischemic, remember, there's something occluding that blood flow to the brain. With hemorrhagic, that is where there is a vessel in the brain that actually ruptures and is leaking or bleeding out into the brain itself. And what type is Mr. Fields at a higher risk for based on his medical history? So if you look here, it shows that he has an irregular heartbeat, right? And remember, atrial fibrillation is one of those things that can cause an ischemic stroke. So if we pull some of this information together, we know he has a history of smoking, which has an effect on the vessels, right? So he probably has some arteriosclerosis as well. He has hypertension, which could be because of plaque that's building up in the arteries, which is going to narrow those arteries, and he has diabetes, which also affects the arteries. So in Mr. Field's case, he is at a higher risk for having an ischemic stroke. And lastly, what diagnostic tests should be prioritized for suspected stroke? So we didn't go into it, but to diagnose a stroke, the patient would have to have a CT scan, and they need a CT scan as soon as possible. So once they suspect a stroke, one of the first things they're going to do is get a CT scan, because remember, time matters in this situation. The more brain tissue that is damaged, the more deficits the patient is going to have. So in Mr. Field's case, they would absolutely want to get a CT scan as a priority as soon as he gets into the emergency room setting, so they could look at his brain, see if he's having a stroke, see if it's hemorrhagic or ischemic, because once they get that CT scan, they will be able to differentiate if it's because of something causing ischemia or if there is a bleed in the brain.